hospital methodology from a percent of charge system to the EAPG-based system. We at the department have worked closely with Public Consulting Group, also known as PCG, and 3M to make this transition. Today's meeting will provide an overview of the EAPG reimbursement methodology, as well as provide a timeline for the implementation and some of the key decisions the department has made regarding EAPGs. Adam Johnson of PCG will be presenting some of the key points regarding the department's decision to transition and provide an overview of where the department is at for this change in methodology. And Dave B. of 3M will be providing a high-level overview of the EAPG methodology works, which will be the main focus of this meeting. With that, I hand the presentation over to Adam. Thank you.
Okay, thank you, Andrew. First off, I just want to make sure that everyone on the phone can hear me.
Yes.
Yes.
Okay, excellent. I'm just going to be, just for the sake of, because we have a lot of callers on the line, I'm just going to mute everyone's line while I'm presenting, and then when Dave's on, he might unmute for questions occasionally, but we'll just be having everyone muted on the phone for most of the presentation, take questions at the end.
Mm-hmm. I already told him we can't hear anything, but now I'm saying, can you email us the copy? Interesting.
Hello?
Did you hear that? Okay.
So I think a few of us are muted, but we can't hear the speakers.
Yeah, I can't hear the speaker.
Yeah. Okay. I've messaged them as well.
Okay.
Can everyone hear us now?
Can you hear us now?
Yes.
Yes. Yes.
Okay, great. How about now?
Yeah.
Yes.
Yes.
All right, good. Thank you. Appreciate you bringing that to our attention. Let's talk about definitions. What are EAPGs? It's for some people, that's some alphabet soup. Okay.
I think it would be helpful to start over. We have heard nothing of this presentation yet.
All right. Let me just basically, I just covered the outline. Some introduction, some basic. Let me just go through that again. General rules, ground rules. This is not in depth detail. In the hour we have, we aren't going to be able to get through that kind of detail. So it's more generally oriented, but a fair amount of detail. So let's ask questions as you feel free, or write them down. We'll cover them at the end. So that's basically what we've talked about. We've talked about the general outline. I'm going to go through some history, some definitions, and then get into detail the structure about the EAPGs and how they. That's where we are. Just covered 2 slides, so that takes us back through that. So definition about EAPGs, alphabet soup, stands for Enhanced Patient Groups. We'll cover a little bit of history of that in a little bit. The background to that, it's a classification system. Classification systems, we're all familiar with them because we've been living with them for many years. Anyone here remember when DRGs came out? I see one person besides a couple of people smiling right here, besides me. I remember when DRGs came out back in the early 80s. And that was the first real classification system that was introduced into hospital payment. Also APCs back in 2000, when they were introduced in August 2000, that was also a classification system. The EAPGs, like them, a classification system. It's really designed to groups services that have similar resource and clinical characteristics. So it covers a broad setting. It'll cover certainly all the outpatient services within a hospital, your day surgeries, your ED, clinic visits, and so on. Some of you may actually have reference labs or reference radiology departments or be used that way. Community physicians will send patients to the hospital to have care provided. It covers all of that. Indeed, it covers many other services that are used throughout the country in other areas, such as freestanding ambulatory surgery centers. And certainly critical access hospitals. I know you have some here in the state. Some for just regular treatment centers, some for freestanding dialysis centers. So it has that broad spectrum of use around the country. In addition to that, as we've already talked about, this is really designed for the entire population. It's not designed just for Medicare population. For those of us who are a little more mature, it covers also those PEDS, those maternity beneficiaries, women with maternity issues. That whole spectrum and those services that you cover that Medicare frequently doesn't. See, that's one of the challenges that Medicaid and other payers have with Medicare, that they don't cover some of that broad spectrum that you do. So it provides that. It's really when we talk about visit, it's based on the ambulatory visit. I'm going to talk about that in a little detail here, what we mean by visit. You and I could probably talk for a couple hours and never come to a conclusion of what we mean by a visit. So
So let's talk about that. It normally looks at that claim that comes in. That being defining the visit. Now, understand, some claims, the from and the through date may not be equal, so it may cover several days. The group can actually differentiate between services that are multiple visits and those that are single. By the way, if you're, I'll ask you to put yourselves on mute if you're trying to crinkle papers or do some work around your desk. It would be helpful here. Thank you. Anyway, so that those single episodes, oftentimes we think of ED visits that may be single episodes and so on. The grouper can handle that. Just to go into a little more detail around that, we have these multiple visit claims. Again, the from and the through dates are not equal. When would the, when I first started dealing with ambulatory services over 20 years ago, most of the time we normally talk about that as a single day. Patient walks in, has some services provided, has some care, and walks out. So they get sleep on bed then. Well, that's not always the case. There are situations, for example, observation that may take longer. In fact, I've seen often heard of observation visits the last 2 and 3 weeks. So observation can really go certainly more than 1 day. Indeed, also we have other claims that cover more than 1 day. For example, what sometimes call repetitive services. We might sometimes in the hospital world call those batch bills or series bills. Those are those cases where a patient may come in for therapy or wound care or whatever for multiple times during a given month. Yes, hospitals will bill those on one claim for that month. So claim starts January 1, ends January 31st. Month, the end of the month. Those are multiple encounters. The patient's been in there several times. So that also is those cases where we might see a from and a through date that are not equal. Well, the grouper can deal with that and is able to use those line item dates of service to differentiate those multiple visits and group according to those visits. It can also take those claims that have from and through dates that are not equal and treat them as a single visit. In fact, some have done that, and it's often done by, I'll say, revenue code, because that's the way it usually happens. So those ED visits where a patient comes in at 6, leaves at 6, has services provided at night, before midnight and after midnight, in that scenario, that's a single encounter. And so they may choose to treat that as a single episode or a single visit, and the grouper can do that as well. And so you're aware of that. So there are multiple things that the grouper can actually do to handle that visit. I told you I'd go through some history. When I was in high school, I really didn't enjoy history. Somehow I've gotten more interested in history in general, but to about outpatient prospective payment because I've lived with that for so long. But outpatient prospective payment really started back in, you might be surprised about this, back in 1990. When DRGs first came on board, CMS found those to be, of course in those days we call it HCPF, found it so successful that they decided they wanted to actually implement an outpatient prospective payment system in addition to their inpatient. And so they signed a contract with, in those days, HSI, soon to be 3M, and actually asked us to do some research. The result of that research was APGs. APGs were used by several states and payers to actually pay prospectively for outpatient care. Well, things sort of came and went. The APCs came along, and we thought that was going to be the answer to all outpatient prospective payment, but it turned out in 2007 that wasn't the case. And so we had a number of payers come to us and say, this APC stuff is just not working for us. So we introduced, in 2008, enhanced APGs. So it's sort of based on what we were able to ground in the 90s, if you like, and then enhanced it to deal with the clinical care the way it's provided today. Because clinical care today is different than it was 20 years ago. Any of us who deal with care, healthcare, have seen that, have been amazed. I've been amazed at some of the things that we actually do nowadays. Anyway, that's a brief history. You can see some of the states have implemented. New York was one of the first in 2008. New York Medicaid, We also have Massachusetts that's done some work in that area, as well as Virginia. And in fact, here's the whole list. We have Illinois Medicaid as well, introduced last year, and others. I'm going to ask someone if you could get me a glass of water. Is that possible?
Yeah, no problem.
I meant to get some of and I forgot. I appreciate it. Thank you. Anyway, there are others who are planning. Now, I have Washington, D.C. Medicaid here on the list. Just to be able help you be aware that this list is now archaic or antiquated because D.C. Medicaid has implemented because they received their approval from CMS for use of EAPG. That just happened a week ago. So D.C. Medicaid is now on the current user list and not the projected list. So why a prospective payment system? Adam covered some of that earlier today, and I certainly would not want to speak for any agency. I've heard from others talk about fairness, talk about some way to manage the growing cost of outpatient care. And what's interesting about that is we look at the Accountable Care Act, that puts more pressure on states to cover that additional care and provide some incentive for efficiency for us as providers to become more efficient. Now, a little bit of comparison between DRGs and EAPGs. Why would I do a comparison between an inpatient system and an outpatient system? Well, what it does is it helps us identify some things that I think are important around EAPG that we need to understand. And particularly thinking about what's happening a week from today. Who knows what's happening a week from today? What's the date a week from today? October 1st, ICD-10. That's right. Very good. So a week from today, we have ICD-10 coming on board. Thank you. I know around my office that is a topic of great discussion. Okay, so let's talk about how that impacts EAPGs. Well, actually, it only impacts us relative to the diagnosis because we don't use ICD procedure codes. Like DRGs use ICD procedure and diagnosis codes. On the outpatient side, we only use ICD diagnosis codes. So that's a big difference. Then we use HCPF and CPT procedure codes. The inpatient side uses the discharge date of that patient, that claim. On the inpatient or the outpatient side, we use the from date on the claim. So when the patient presents, that's a big difference. Why would that be? Well, let's just take an example. We have a patient who comes in September 30th. So next Thursday, a patient comes in and then leaves on the 1st. How do we code that? Well, I know what CMS says. CMS says you should separate those, split that claim, so you have two separate claims. That's what they tell us to do. From a practical perspective, it may not be necessary because we use the from date, and we could potentially, and we don't use ICD procedure codes, so potentially you could get by on the outpatient side with not doing that. But certainly CMS suggests we split. That's what they've been very clear about that direction. On the inpatient side, we have a single DRG. So when I see a claim, I see a DRG. Not so on the outpatient side. We have a claim, we may have many EAPGs, just like the APC world. So let's look at and let's compare EAPGs with APCs. Now we're looking at two outpatient prospective payment systems, actually two classification systems. They're not; these are just the classification piece, not the entire system. So let's look at that. With APCs, it gives us numbers. We have many more APCs than we do EAPGs, but we have many more medical groups in the EAPG world. So those are significant. We talked about that earlier, that is Adam did, when he talked about helping the system provide more clinical information. That's one of those particular areas that does that. Editing. APCs has an extensive set of edits. Those OCE edits, if you like, there are about 94 of them today that are defined, not all used, but there are about 94 of them. Many of those don't apply to what you do. EAPGs doesn't do any. Actually it does validation to make sure the diagnosis codes are correct. But other than that, it does no editing. The reason for that is we know that you already have edits already in place. And we don't want to create something that would conflict with what you're already doing. So we don't have any. Modifiers. Well, they all both use modifiers. On the APC side, some have implications. On the EAPG side, there are some that have implications. I've listed some of those. So in many respects, they're the same. And we'll talk more about modifiers later. Let's talk about status indicators. Anybody who lives with APCs, if someone says Appendix B, everyone knows what that is. If I say status indicator A, we all know that those are paid by fee schedule. Now, those of us who live with that day in and day out just know this because we live with it all the time. Well, on the APG side, we don't have status indicators. So we have a little bit of different language we need to talk about. We do have EAPG types, and we'll see those. And those EAPG types help us in actually grouping. And those are some significant issues. We don't typically use fee schedules. On the APC side, we have many fee schedules. We have a lab fee schedule. We have therapies. We have ambulance. We have DME. We don't use fee schedules in the EAPG world. Now, that doesn't mean that they can't be used. It means natively that the EAPGs doesn't use them. But there are others who use them. So Wisconsin Medicaid has laboratory services that are paid by fee schedule. And so that is possible. But that's not the native way that EAPGs are built to work. Packaging, APC does some extensive packaging in the sense that you have a status indicator N, indicating something's not paid separately. They have conditional packaging with Q1, Q2, Q3, and so on, those status indicators. And they do some comprehensive APCs as well as composite APCs. So they do some extensive packaging in that respect. On the other hand, we don't use those logic in EAPGs. We use packaging for ancillary services and consolidation for significant procedures. We'll explain those in some detail later on. Now, we've talked about this to some extent. It's always nice to refer to what data sets are needed to work with EAPGs. Well, the answer really is, and you can see some detail here on this slide, but the answer is what you're sending in on your 837I is just all that you don't need to send anything else. That provides all the information needed for EAPG processing. So there's no additional data field, data element, or anything. And as I say, you can see some detail here around that. I'm going to just bypass that. The next slide talks about outputs. Now output, in addition to what you've already put in, will output the EAPG types, categories, give us information, some flags, whether this item or service is packaged or consolidated or somehow discounted. So it gives us a number of flags. From a hospital perspective, there are a couple things that means for you. One of those is you have, oftentimes, most hospitals have a lot more outpatient visits than they do inpatient visits. And so just by the sheer volume of claims, they're going to have a lot more data they have to store. Also now we see a lot more data fields coming out of the EAPG grouper than come out of a DRG grouper. Even APR DRGs doesn't put out this much information. So the question really comes around is, are your information systems prepared to handle this information? And make sure that you also not only can store it, but sometimes you may have to store both in APC and in EAPG, depending on how crossover claims or dual eligible patients are handled. So that's something to think about. And also then you want to ask yourself the question of what kind of information do I want to have at the back end? How am I going to report on this? And what am I going to report on? And so you need to make sure you calculate and have the data to be able to report on those things you like. For example, you may ask yourself, well, how often is this service discounted? Or how often is it packaged? Or whatever. And then that means you need to have those flags stored. So that's information just food for thought. as we go through that. Now, I mentioned that the EAPGs is a classification system. It's not a prospective payment system. APCs is a classification system. It is not a prospective payment system. Why would I say that? We all talk about APCs and EAPGs, and everyone says, well, how much is it going to pay? Well, the EAPGs is just a classification piece. And our patient prospective payment system uses classifications and a payment logic or methodology that is then used to calculate the reimbursement. So an OPPS, or outpatient prospective payment system, includes both of those. And in the APC world, it also includes editing on the lower left-hand side. The EAPG group, or 3M, provides that and does some, as I say, sets flags. The actual information relative to relative weights, base rates, those things that are used in calculating payment are defined, in your case, by Colorado Medicaid. So that's something that we have Andrew here who's going to be working through that with Adam. That's defined the actuals of how much is there. But the classification system does answer a very important question. It answers what is going to be paid. Let me give you an example of why I say that. What is going to be paid? Something we might be familiar with. Anyone ever have a bigger trip when buying a new car? Anybody in here in the room ever bought a new car? How does that work? Isn't it great to come out of the car lot with that brand new car smell? Well, let's talk about sort of that process. Because I've done the same thing. You search around for money, decide what car you're going to buy. You go up to a salesperson and say, I've decided I'm going to buy that car. Well, what's that salesperson going to say? He or she's going to smile and say, that's a good condition. You're going to love that car. Okay, they all say that. That's to give you some validation. But then they're going to ask you a question. They're going to say, do you want any options on that car? And you'll say, oh, for example, you want chrome wheels. You want a moonroof. You want the electronic door locks. I used to say, how lazy can you be? Now I can hardly live without my electronic door locks. But anyway, it's funny. And then you're going to say, well, I like this. He said, now, I have a package that includes all of those things. It includes some other things, but it's cheaper than if you bought those a la carte. So you decide on your car, you decide on your options, and now you know what you're going to pay for. So now there's that what. And that's how we look at, I look at this issue of the classification system. Let's look at some of the details around that. I told you we'd see the EAPG types. These are the EAPG types. There are 13 of them. It used to be 8. 1, 2, 3, 4, 5. Those used to be the 8. However, over time, we've had some input from those who are using the system that said, we'd like a little more granularity around those significant procedures. It's really hard for me to say that a radiology service, if you like, is a significant procedure. So if we really think of those as sort of ancillary. But anyway, so we have a discussion on that, and we came up with these other 5 types you see here, the 21 through 25. And so now there are 13 EAPG types. However, because those new 5 types came out of the significant procedure, that EAPG type 2, we treat them all as if they're significant procedures. And so as we talk about significant procedures throughout this presentation, I think about, and I'm talking about all 6 of those EAPG types. So just be aware of that. That's why they're all in red. That's why you see that little call out. Now let's define the types of EAPGs. Actually, the procedure types. The definition of what those procedures are. So we talk first of all about significant procedures. What do we mean when we say significant procedure? Well, typically we're talking about those things that are resource intensive, they're scheduled, and that's why you come in. So we'll say they dominate the reason for the visit. We think of things like a stress test, an MRI, colonoscopy, and so on. Those are some examples that I think of. Certainly when I had my MRI years ago, I didn't walk in one day and say, gee, I'm here for an MRI. I had to schedule that, okay? And they're expensive. Any of us who had that privilege know that they can be expensive. So Now, that doesn't mean that everything, all significant procedures are scheduled, because ED visits also have significant procedures. And certainly most of us, I don't think, schedule our ED visits. So there are, I think of them as significant, meaning invasive and expensive. Just as a general way of looking at that and thinking about that. The second type of procedure is those ancillary services or ancillary procedures. These are services that are ordered by the physician for care and if you like, diagnosis of the patient. Things like immunization, things like lab tests, simple radiology services, playing films, those kinds of things. And lastly, we have this third type, this incidental. These are services that are used in conjunction with a medical visit and are integral to that medical visit. I remember when we were expecting, I say that very generically because I was never expecting. My wife was always expecting. But anyway, so when we were expecting, we'd go in to see the physician for her monthly checkup. And every time, he did a urine dipstick test. Now that, we didn't go in just for the dipstick test, we went in, it was part of that visit. So in that case, it was integral to that care. Now why is it important we understand those incidental services? Well, the group will tell you what they are, first of all, so you don't have to memorize that list. But because they are always packaged and never paid separately. That's why it's important to understand that. Medical EAPGs. We'll define this in a little detail in a minute, but medical EAPGs are defined by the primary diagnosis code. And in fact, the primary diagnosis code is the only diagnosis code that's absolutely required. Now, does that mean I'm suggesting we only send in a primary diagnosis code? Absolutely not. We want as many diagnosis codes as possible. But it is a challenge on the outpatient side to get a significant number of diagnosis codes because we just don't seem to see that. So send in as many as you like. The primary is the only one that's required and used for defining a medical visit. With that, let's talk about the logic. Now you're going to look at this flow chart, and your eyes are going to get a little big, and you're going to say, oh my goodness, how am I going to understand this? This is awfully complex. This sort of eye chart as we looked at. But actually, this is relatively simple. Let me explain why I say that. There are 3 steps. You see the number down the left-hand side, 1, 2, and 3. There are 3 steps, and that's all there really is. The first step is, do we have a significant procedure? Now, if we do, then we assign significant procedure EAPGs. Now, what's on the gray? The gray on the right-hand side really means that we can have more than one significant procedure that gets an EAPG assigned to it, and we can also have ancillary services that are also assigned EAPGs during that process. So that's what the gray means on the right-hand side. It just means there's more than one. But if we don't have a significant procedure, then we look to see if we have a medical visit indicator. Second step is to look to see if we have a medical visit indicator. Now, what is an MVI? You notice we all seem to like acronyms, and you notice I tend to talk in acronyms. And I apologize, certainly keep me honest if I don't explain those acronyms, let me know. So MVI really means medical visit indicator. What is that? Well, those are those evaluation and management codes, those E&M codes, that we're already using. Hospitals already report these when they're reporting a medical visit. 99201, 99211, 99281 for an ED visit. Those are those evaluation management codes. Those are also those MVIs. If we have an MVI, we look to see if we have an MSSF or a major sign, symptom, or finding. If we do, then we'll assign that major sign, symptom, or finding EAPG. Of course, what is an MSSF? Well, those are diagnosis codes that really dominate that patient's care. And we look at all diagnosis codes for that MSSF. So what do you mean dominate? Well, let me give you an example. That's probably the best thing I can do. As I've matured in life, I've started to become a little more honest in seeing my physician for my annual physical. Sort of annual, anyway. But when let's say, for example, I've been seeing my doctor for my annual physical, and he's doing that, he's tapping my knee, see if my reflexes are still alive. And while I'm in there, I have a grand mal seizure, or I have an MI. You think he's going to care about that physical anymore? No, he's going to care about that grand mal seizure. That's going to dominate that visit with my physician. And so that's what I mean by those major signs, symptoms, and findings. There's a whole list of what they are. And certainly that's in the definitions manual. But if we don't have an MSSF, we look to see at the primary diagnosis, going to use the primary diagnosis code to assign that medical visit to the EAPG. Now, if we don't have a significant procedure, step 1, we don't have a medical visit indicator, step 2, we go to step 3. That means one of two things. We either have an error condition or we have an ancillary-only type of claim. Or it may just be some drugs, whatever. But we only have those ancillary type services, and we assign those to the EAPGs. Now, sometimes what's said is important, but what's not said may be more important. Now, as you look through this, what did I not say? I didn't say, and a question that comes up all the time is, what about that condition where I have both a significant procedure and a medical visit on the same claim? If you remember how I walked through this, I said if we have a significant procedure, we assign significant procedure to EAPGs. And if we don't have a significant procedure, we go to the medical visit. I didn't talk about both. Well, EAPGs, by default, will not look, if it has a significant procedure, will not look at that medical visit. Now, we have modifiers, which we'll talk about here in a minute, that may help with that. And there are ways of dealing with that. But that's the way it natively works. So those medical visits, I'm going to give you an example, because this is so important to understand. I want to make sure we have that. So I have an example here. I have actually two examples. I have a patient who came in with some diabetes issues and some strep throat. Now, if we think about this, going back to that question we talked about, that clinical clarity, so to speak, what would we do if we were coding this in APC? Well, we would use the E&M code G0463 if these were clinic visits. Didn't matter how long we were there, the patient was there, didn't matter how complex it was, we would use that G0463 because that's how we bill for Medicare. And that's all they accept on clinic visits. What does that tell us about that patient? It tells us nothing. That's simply we saw a clinician. Doesn't tell us why, doesn't tell us how long, how complex, what the acuity was, doesn't give us any information. Whereas when we look at APCs, or pardon me, EAPGs, as we go through this, we'll see some of that differentiation, that clarity that we can look at and use. So let's go through these two examples. Here's that first one with diabetic issues. You'll notice I've sort of highlighted what the primary diagnosis code, that 25090, and we see the EAPG 711. Now let's look at those services. What do we have on the left-hand side? Now, I'm sure that your eyes can't read this much better than mine can on my screen, but let's look at those. We have an E&M code up here at the top, the 99215. That's a clinic visit for an established patient. We also have a lab test, the 80053. That's a comprehensive metabolic panel. Lastly, we have a venipuncture. That's what that 36415 is. So those are the three things. Now, maybe there were other things. I don't know. But this is what I wanted to illustrate with. You can see how that would pay. You'll notice that the comprehensive metabolic panel pays separately, and we get paid for that E&M medical visit. But that venipuncture is going to be packaged. Now, let's look at this next example. This is the one with strep throat. You notice I highlighted the diagnosis code of 0340. Now, at one point in time, I sometimes forgot to put the 0 in front of, talk about diagnosis code. Forgot to put the 0 in front of that 340. I can tell you a 340 is not the same as a 0 for 340. I'm sort of a math guy, numbers guy, so it's a big thing when it comes to diagnosis coding, certainly in I-9. Anyway, just a sort of a humorous comment. So we see here we have a clinic visit of 99212. That's an E&M code for an established patient. We see a lab test at 86403. That's the quick strep test. Venipuncture. Basically the same service for that patient, but we see we have a different EAPG. And I can assure you that they will not have the same weight, that we'll receive different payment around those. So we see how that's handled. Now, as you look at these numbers here in this, all my slides, understand that I don't want Okay, hang on a second. I don't want you to take those numbers, go back and say, here's what they're paying, because they're fictitious.
Just a quick question for clarification. Will the EAPG number be replacing the revenue code number on the?
Can you repeat the question for the caller?
Okay. The question really is around revenue codes. Does the EAPG replace the revenue code? The answer is absolutely not. Okay? The revenue code is part of that, if you like, the 837 definition. And therefore, that needs to continue to be built. Oftentimes, you'll see a revenue code with a HCPF 250, for example, pharmacy 272 for med-surg supplies. Still need to build those revenue codes. The EAPG is assigned. Doesn't use revenue codes. This is the HCPF code or the CPE code. Still need to build as you've always asked. Okay. Was there another question on the phone? Remember, if you're picking papers or working around your microphone, please mute yourself. Okay, so that just illustrates sort of the importance of that primary diagnosis code. Now let's talk about packaging. I indicated we had packaging EAPGs. There's this general concept about packaging. That's what I want to talk about here. When we talk about packaging in general, what are we talking about? It really means, for payment purposes, the inclusion of payment of one item within payment for another. So around here is to remember that just because you see it, you get a remittance that 835. All right, so hopefully you can still hear me. We muted everyone, so you're going to have to, we'll unmute you at the end for questions. So go ahead and send in emails if you like, or notes if you have questions. You'll take your time. So, where are we? We're talking about a concept. Just because you see a zero on a particular line item on that remittance device, it doesn't mean there's no payment. It means there's no separate payment. And if you talk to Medicare or you talk to anybody else who uses a prospective payment system, they will tell you that. There's no separate payment. But there's still payment in the way the weights are created. It includes those items that are packaged. There's additional weight applied to those items that are going to be paid separately. So you'll see that applied statistically across the various services. That doesn't mean it's dynamic. It means that it is statistically important. So let's look at that in a little more detail here. What that looks like. Now, again, the general concept. I'm going to talk about the fact that when you think about packaging in EAPGs, there are two different concepts. We talk about ancillary packaging, which applies only to ancillary services. Here on out, you'll probably hear me say packaging. When I talk about packaging from here on out, this is what I'm talking about. We also have significant procedure consolidation. Now, you'll probably hear me talk about consolidation. It only applies to significant procedures. Therefore, the proper term or full term is significant procedure consolidation. But I found that saying significant procedure consolidation 10 times real fast is really tough for me, so I tend to say consolidation. It's just easier, and we can get through this faster. So let's go through that. We're going to talk about packaging to begin with. Again, we're talking about ancillary packaging. There are two items, if you like, that apply to ancillary packaging. That is, one is there's a list, a uniform list of services that are going to be packaged, or are candidates for packaging. And there's a situation or logic that applies to when they'll be packaged. Let's look at that in detail. So here is the default or the uniform list. Now, we call it officially a uniform list. Some will call it a default list. Some will call it a standard list, whatever. This is the list that comes with the software out of the box. That's what 3M creates. It doesn't mean this is the whole list. We sometimes see that some payers will want to add to this list, and some will want to remove from this list. And they all have that functionality within the grouper to enhance this list or to, if you like, to modify this list in some way and reduce it in size. So that's something that can be decided and worked on. But this is the default list, the uniform list, and so we'll call this, and I tend to call this the list in my presentation. So if I say the list, this is the list I'm talking about. So how does this work? What's the logic behind this? So in this packaging, there are two conditions that need to be met. One is it has to be on the list. The EAPG has to be on the list. And two is we have to have a significant procedure, medical visit, or actually per diem service also on the claim. Both conditions need to be met in order for something to package. If it does not, both conditions are not met, then it doesn't package. So let's illustrate that. Here's just a general illustration. We see this EAPG 10 level 2 decision, and when we say over here on the right-hand side, the action really talks about those things that will pay separately, and if it says include in payment, it means it's paid separately. Okay, it talks about consolidate. We'll explain consolidation later. But here we see this package means it means it's not going to pay separately because it's going to be packaged, so it's not going to be paid separately. Let's look at that situation. Let's go on and talk about significant procedures and how that works. Let me step back and talk about packaging for a minute. Let me give you something to think about. So if I go to a hospital-based physician, to a clinic, and see a physician, and he sends me off to get an X-ray or to get some lab work done, what's going to happen? What's that bill going to look like from the hospital? What's going to have that clinic visit with that physician, and it's going to have that other service, that ancillary service also on the claim. If that ancillary service happens to group to an EAPG that's on the list, all that's going to be paid separately is that medical visit. On the other hand, because the ancillary service is going to package. On the other hand, if I see a community-based physician who sends me to the hospital for a radiology test, if it's a plain film and it's on the list, then the hospital, because I have not seen a hospital-based physician, or actually a hospital-based clinic, a physician in a hospital-based clinic, someone who's employed by the hospital, if you like, the hospital doesn't bill for that medical visit. They only bill for that radiology test. And so because both conditions are not met now, the hospital gets paid separately for that radiology test. So just give you a sense of how both conditions aren't met, it's not going to package. Let's talk about significant procedure consolidation. Sometimes we call it bundling, and so on. This really applies to the fact we have some efficiencies of scale that are really come into play when we provide there are two different services at the same visit. And so that's what we're talking about here. There are two types of consolidation: multiple, same, EAPG consolidation, and clinical. And we'll explain those here as we get through that. First of all, let's talk about clinical. This means there's some logic involved in how this is done. There are two related services. And we're going to look down here at this, down here, the way you read this chart, this is an actual excerpt from the logic. It's multi-pages long, so I just pulled a small portion out here. You look at the part that's in bold, that becomes the primary, the one that's not in, that becomes the primary EAPG, and the one that's not in, that's not in bold and is indented becomes the secondary or the subordinate. And the subordinate gets consolidated into the primary. So if you down here and looked at this EAPG 8, and we might have the EAPG 3, 5, 6, if we saw any of those also on the claim, then the EAPG 8 would pay separately, but the others would not pay separately. So let's look at an example of that. So here we have a patient. Now, this is what I affectionately refer to as, stay here, as the porcupine example. All right, and that's so what you see is patient information to begin with. And we see this 99211, that's the clinic visit. We now see we have 2 units of removal of foreign body. So we have level 3, EAPG 3. Notice that here we see it says consolidate. Now, why would that happen? Well, remember, we looked over here and we see EAPG 4. And we actually see 2 of those. So if we go back to our logic, we see this EAPG 4 is the primary, EAPG 3 is the subordinate. And so if we see both of those on the claim, as we do in this example, the 4 will pay separately and the 3 will consolidate. Now that's the clinical piece of that. That's clinical significant procedure consolidation. Now we actually, over here we have actually 2 different services, a drainage of an arm lesion and a drainage of a lower leg lesion. Similar services, both grouped to EAPG 4. Now we have same significant procedure consolidation that comes into play, and that's why the second occurrence of EAPG 4 consolidates and does not package, or does not pay separately. So the way that looks, for payment purposes, is it looks like this. We have a significant procedure, therefore we do not look to see if we have a medical visit, and we see this EAPG 4. The first one gets paid, and the second, and the 3 and the second 4 don't get paid separately. Again, these numbers are fictitious, created by me to illustrate a point. All right, so this is not real. Now, modifiers do come into play, do impact us. I talked to you earlier about modifier 25. Modifier 25, if selected to be used by the department, says that if you have a medical visit and a significant procedure, you can get paid for both. But you need to apply a modifier 25. I always caution people, use a modifier 25 appropriately and carefully. CMS says that modifier 59 is the most used and most abused modifier. I think 25 is probably the most second. So be careful about that. But if it's appropriate to use it, and you'll get paid for both. We have other modifiers. Let's talk about a couple of these. You can read many of them. Modifier 59 actually bypasses or really overrides consolidation, and so we'll see that. As do some of these others, we see the distinct modifiers, those X modifiers, therapy modifiers do the same, clinic modifiers do the same. Well, let's go back here and talk about these up here. So modifier 50, 5-annual modifier. It's important that you use modifier 50 and don't try and code the same service with an LT on one line and an RT on the second line. Why would I say that? Well, first of all, I think it's poor coding practice. I think guidelines don't support that. Although some payers require it, so I know some cases it has to happen. But from a practical perspective, then, here's what to remember. Remember we talked about same significant procedure consolidation? If we have 2 of the same HCPF codes on the claim, do you think they're going to be grouped to the same EAPG? Yeah, I think they will. Now you have 2 of the same EAPGs on the claim, so what's going to happen? First is going to pay, the second one's going to consolidate. So you only get paid for one of those. Normally, the way the modifier 50 works is it's set up to pay at 150%. So practically, you benefit by using modifier 50 and following the guidelines. Just not something I have any energy about. I just deal with this a lot. Modifiers 52 and 73. These are discontinued or terminated services. The 73 is terminated before the administration anesthesia. In these cases, these would impact you by creating a 50% discount. So that's what happens with those 2 modifiers. PA, PB, and PC. What in the world are those? Anyone know off the top of your head what they are? These are what I call the never event modifiers. It says I performed the wrong service on the wrong site on the wrong patient. Okay? That's oh good. I see somebody back there saying yes.
I know what it is.
All right, very good. So that's what they are. And normally what will happen is that line will not pay because of that. Now let's look at this example we just looked at previously on consolidation with a modifier. Now added the modifier 59. Notice I added it to that removal of foreign body. And we now see that the clinical flag clinical significant procedure consolidation applied. So let's look at that. We see the same thing here, but when we actually look at the payment of what happened, now we see that that service that previously did not pay, that we now have a 59 on, pays separately. The 59 actually overrules or overrides that consolidation. Bless you. So that's just the power and the impact of modifiers. Please use them appropriately and properly. Observation. How's my time? I'm just about out of time. Is that right?
You got about 10 or 15 minutes.
All right. I'll use them.
Yes, please.
Okay, tell me I have about 10 minutes to go. All right, let's talk about observation logic. Now, a couple things. I've been in a number of states where the information around observation logic is sometimes hard to come by, and I'll explain why that is. Observation is assigned. It's based on several data fields. One is you have to have a diagnosis code. Always have to have a diagnosis code. Two, you have to have a set of HCPF codes, and you have to have a unit of service. Normally, what happens, it can be set up with one of these four options. No units required, minimum of 4 units, minimum of 8 hours required, or a minimum of actually conditional really says this is specific for maternity. It applies 4 hours to a woman who comes in, if you like, false labor, or sometimes in there for maternity care. So let's look at a little of that in more detail. So I said we have to have some HCPF codes. In particular, we need to have the G0378, because that is how you report hours. If we look at the other observation codes, the 99218, the 99219, that is for a day. This is the only way you can report hours. Now, just the first bullet here really talks about the fact that if we have a significant procedure or a per diem, observation will always package. That always packages if we have a significant procedure on the claim. So if we have a patient comes in and has some type of surgery done, for example, let's say a patient comes in and has a carpal tunnel release, and has some anesthesia, maybe it's general. Now, was it general or not, I don't know. I've never had one. But let's say in this case they didn't. So they keep them in observation status for a while. Actually, it's recovery status until the patient gets out of the general anesthesia. Well, that will package because we have that significant procedure. Okay. Anyway, we need to have a G0378 also, and they really report the hours. Again, there are some decisions that can be made that apply to this, but as we've talked about, let's look at the two types of observation. We have ancillary and we have medical. First of all, we look at the ancillary. If we have ancillary observation, there are a few things that are also required, in addition to the G0378. We have an E&M code, so we have one of those medical visit indicators. We see the list here. Includes that G0463. So what that means is, if you really want to use the G0463, because you're using that for Medicare and you want to have sort of common practices, it will work here. And you have a medical visit, the EAPG is now assigned, so we have the G0378, and we have one of those E&M codes. In that case, the medical visit is going to be assigned based on the primary diagnosis code, is going to be assigned that observation of the EAPG, and it will pay separately. So in that case, we have the medical visit that's paid separately, and we have the observation that's paid separately. The observation gives them the EAPG 450, and they're both paid separately in that scenario. However, sometimes we may not have one of those medical visits. The patient may come in, maybe a drug commit, and so we have this other condition where we call it medical observation. And so here we have one of these OBIs, my acronym again, observation visit indicator, and you see the list there. Notice the bottom includes the G0379 that we use in Medicare. But we have no medical visit indicator. We've not seen a clinician, so we don't have that MVI. And that's in there, but we still have our G0378. We have the appropriate number of hours. In that scenario, the OBI is going to be assigned one of these medical visit EAPGs, 500, 501, and 502, based on the diagnosis, and you can see the definitions here, and those diagnoses are so that's sort of the what gets paid separately. So that's how observation works. I know I covered that very briefly. Many of you would probably like to see that in more detail, and another time we could probably do that. Well, let's talk now about, then through the what, let's get sort of the bottom line. Oftentimes when I go out to present to new people, they'll say, first question they ask me is, how much is this going to pay or that going to pay? Well, you need to talk about the what, now we can talk about the how much. So that's what the reimbursement calculation talks about, is the how much. So just be aware that every EAPG is assigned a weight. That's really developed through the auspices of the Department of Health and how that's handled. Those weights are really, it's a relative system, and they include, for the items that are packaged and not paid consolidated, not paid separately, they include some additional add-on weight applied to them. Every EAPG in that visit is multiplied by appropriate, actually as it has an appropriate weight, and it's multiplied by a base rate. We have some other information here about that. The visit is a sum of all the weights, sum of all the payments, and really what this talks about, we talk about consolidation and packaging, we talk about incentives. These are what provide the incentives. Now let's look at the detail. And this is just some examples of what some weights might be. I mean, we can look at this by sheer fact, we can look at that and say, well, gee, I know an echocardiogram isn't nearly as resource intensive as implanting an AICD or a defibrillator. Just by knowing what that, we can look at it and say, oh, it's obvious. But this weight system helps us define that acuity and differentiate things that Adam talked about earlier, making this more transparent and more fair, more level. So what we have, again, anything that's packaged or consolidated is not going to be paid separately, so we'll get $0 on that. So we take the conversion factor or base rate, whichever we want to call that, times the adjusted weight. Now, what is an adjusted weight? Well, let's talk about that. First of all, we have the weights we talked about that every EAPG has. It's adjusted if there's some type of discounting that's applied. Remember we talked about some discounting earlier? We talked about 5 annual discount, 150%. We talked about discontinued services, 50%. The way we do that is we normally, in our system, is we multiply the weight times that discount factor to get an adjusted weight, and we multiply the adjusted weight then times the base rate. And then we take every line item that's separately payable, we sum it all up, and we get that final claim payment. Now let's define discounting. Now I've talked about some. You see those at the bottom. But I didn't talk about, I alluded to, but did not talk about like discounting for significant procedures, or what about multiple ancillary services? So let's talk about those in particular. The way it works, remember we had that example where we used the modifier 59, and we saw that line item that previously didn't pay, is now being paid. It was paid actually at 50% because it is the lower weighted one. So if we have multiple significant procedures that are separately payable, the highest weighted one is paid 100% and all the others then at 50%. That's sort of the normal setup. And that's sort of a standard that can be modified, but that's sort of the standard. We then have multiple unpackaged ancillary services. So we noticed earlier that comprehensive metabolic panel that was on the claim, it paid separately because it wasn't on the list. So here we have the situation where we have multiple unpackaged ancillary services. That means they're probably not on the list. They're paid separately. But with the ancillary services, it's possible to have a couple things happening. You could have two services that might have the same EAPG, and you might have a situation where you have two different lab tests. We may have a lab test in radiology and plain film that also are on the list. So that might not be on the list. That might be paid separately. So we have a case where we have the same EAPG ancillary services, and we have a case where we may have different. So what happens in that case? Well, let's look at that example. Actually, I have an example in the next slide. Let's go ahead and look at that. Here we have an example to illustrate the The first three items on this example are significant procedures. You can see that because it tells us that in the fourth column. And the last four services are ancillary services. We see the HCPF codes, the description, the EAPG assignment, what type of service it is, and then what the adjusted weight is. Now and then the payment percentage. So we see the highest weighted in that vena blockage, repair of the vena blockage, is paid at 100%. It's the highest weight. The others are paid at 50% because they have a lesser weight than the first one. Even if you were to multiply those weights by 2, it would still not exceed the weight of that first one. So they end up having the lower weight associated with that. So they're discounted. Now the last four are all ancillary services. Now there are three different conditions we see here. The last two have the same EAPG. Okay, both ancillary services, both paid separately, have the same EAPG. In that scenario, one gets paid at 100% and the other at 50%. Usually the first is paid at 100% and the second at 50%. Now sometimes in my mind I think, well, why didn't we pay the higher weighted one 100%? Well, they have the same EAPG, they're going to have the same weight, so it really doesn't matter. So typically we pay the first 100% and discount the second. Now the first ancillary service, that comprehensive metabolic panel, right here, that 80053, it has a different EAPG, still an ancillary service, but because it's a different EAPG from the others, it's going to be paid 100%. So if two ancillary services have different EAPGs, they do not discount. The only time they discount is if they have the same EAPG. And of course, go back to where we were. And of course, this other one here, third from the bottom, this prothrombin time, that's on the list, and we have a significant procedure, therefore it's going to package, and we see that that's what it is. Now we've already talked about this thinking about information systems. I'm not going to cover that in any more detail. What we want to do now, I think, is open it up for questions. Let's unmute. Echo here, feedback, we're not able to really hear. Anybody in the room or anybody on the phone?
Actually, I have a question.
Okay, go ahead.
Well, it's more of a request. Is there any way we can get these PowerPoints somehow?
Certainly, you certainly have that. You have the.
I'm sorry, I can't understand what you're saying.
Yes, we have the PowerPoint. We'll also have a recording of the presentation that we'll be able to distribute after the meeting.
Oh, okay, so it will be just a recording that I would have access to?
I'm sorry.
Sorry, everyone. Yeah, my line was muted. So just,
So we're actually going to email all of the handouts and the presentation to the entire group. So you'll have everything to take a look at.
Yeah, so we passed out a handout that I'm showing right on the WebEx right now. So everyone on the phone will be sending all of these documents electronically, both the handouts that we mentioned and then the PowerPoints as well. And so just wanted to walk through this milestones document. So I've got it up on the screen here. Just kind of walking from the beginning to see where we're at this point and where we have to go until we get to implementation. So last year we started with a kickoff meeting with 3M and the department, and in the next month we started evaluating claims data and to establish, see if there's any errors or any problems with it, with the data, to make sure that it was ready for EAPG. And all of that, checked out. There weren't any big issues. And then the department and PCG began to have discussions on both high-level policy decisions and also group option settings. And that continued on until this last spring. And when we finalized weight-setting decisions and rate-setting decisions, and we began to set some preliminary weights and rates to get an idea of the fiscal impact of, really the question we wanted to answer in the beginning was, what's going to be the impact of shifting from percent of charge to EAPGs? How is that going to affect hospital payments? And that was the preliminary fiscal impact that we put together, and we've been reviewing that since July, trying to come up with good transition options, because obviously as things are changing, along with the payment methodology going to change, hospital billing is probably going to change, because procedure codes were never really used before, but now they're going to be very crucial. So we know that claims data is going to begin changing, so we want to accommodate for that sort of refinement over time. So any sorts of big impacts, we'll try to mitigate it with a transition option. And obviously today we're in the first meeting with you all, and just as an introduction to the EAPG system, the next meeting on November 20th will be a review of the policy options decisions, as well as the weight and rate setting methodology. And that, if you could go ahead and pass that. So Michaela, for everyone on the phone, Michaela's passing around also the policy option decision. This is the other handout that's mentioned in the slideshow. That's also going to be emailed out to you all after the phone call is done. That we're handing that out now. It's not really something, we're not going to go over that right now. It's more like for you guys to take back and review in between now and the next meeting, and then we'll be going over this document in the next meeting, but we wanted to give the opportunity to start looking at it, because now that you've gotten your feet wet with EAPG, you're going to be able to look at that and come up with some questions, and so we can hit the ground running when we come to the next meeting. And then after that, we'll have a meeting in around February. We haven't pinned down a date yet, but that'll just be kind of a further follow-up for any more questions, updates on the EAPG implementation project as a whole, and then going back to milestones towards implementation. Probably around March, we'll begin HP, MMIS technical meetings, trying to get the system ready to implement EAPG, and then we'll begin calculating the final weights and rates that will be used for fiscal year 2017 when EAPG goes live November 1st. and that go-live date is a date of service-driven change where on or after that date, all claims of those dates of service on or after November 1st will process through EAPG. And then in the meantime, between those weights and rates, provider training meetings will begin probably around August, where we'll probably be doing some maybe visits and meetings to talk about maybe a little bit more of the nitty-gritty of billing changes and how EAPGs is really going to affect the billing that the hospitals are going to have to do and address any billing questions that have come up since our initial meetings. That's kind of the overview of this milestones document. And back up. And so just in general, are there any questions in the room with anything else that we've talked about? Even with Stacy's presentation, are there any questions that you come up with? Yes, go ahead.
So it's my understanding that right now, with the cost-charge ratio, a few years after the payment is made, Department needs to retrospectively go back and maybe reconcile. Is something like that going to be happening still with the EAPGs?
So the question was whether or not in the future with EAPG's implementation will there be payment reconciliations going forward as there has been. Did you?
Yeah, this is Andrew. We're going to be moving away from that entirely. Once we've implemented EAPGs, we'll be phasing out that reconciliation process as it happens. We envision that once we've completed with the reconciliations, we'll be moved away from that entirely, but there will still be a transition period after the go-live date. We'll be doing reconciliations. For the previous years, yes.
Okay. But you won't be reconciling any claims that are with EAPG?
That's correct.
Cool.
Any other questions from the room?
We have a little extra time too, so if there's something else you want to talk about while we have Dave here,
yeah, anything EAPG, anything that's just maybe there's one little thing that you're just not getting that he talked about. Feel free to ask that right now. No, I was and then I just wanted to make sure everyone in the room, and then I was going to switch over to everyone on the phone. So I'm going to ask again that anyone who doesn't have a question, if you could please mute your phone. I'm going to unmute everyone. Hopefully we won't get any more crazy echoing like before. Anybody on the phone who has any questions? Safety or the department?
Hey, will you guys be sending out any projected impact to the hospitals in the near future?
Could you repeat that question?
Yes, this is Doug Lemieux with Centura. Will you guys be sending out projected impacts by hospital at some point in the near future? It sounds like you guys started working on that over the summer. I apologize if you did already send those out, but just asking about that, because a lot of folks will be asking those type questions from our system. Thanks.
The question was, sorry, the question was, are we going to be contacting people in the near future? Okay. So the follow-up meeting that we have scheduled in November, we're going to be discussing the rate and weight setting methodologies for hospital-based rates and EAPG weights. As for the specific, as for a timeline of when we deliver impacts to each hospital. I believe it should be after that time and in anticipation of the February meeting as well.
Does that answer the question?
It sure did. Thanks much.
Okay. Any other questions from Hey, we're going to do all again just to make sure that we don't get any more people.